Good evening, everyone. I hope you can hear me loud and clear, and welcome to our IVF webinar tonight. As you can see, we have another special guest. This is Dr. Elias Tsakos. Some of you already might know Dr. Tsakos as he has been our presenter before a few times. So I'm very excited to have you back with us again. How are you feeling tonight, Dr. Tsakos? How is it going in Greece?
Hello, it's going very well. Hello, everyone. Wonderful, Caroline. It's been very sunny and very beautiful day today, and we're very happy. We're still like almost on holiday. We've only had our Easter a couple of days ago, so we're all very rested and full of energy.
That's great to hear. I'm very happy that you are rested in such case, because I'm sure it's pretty busy every single day. So I'm glad that you were able to find some time and spend it this evening with us. And so thank you so much for joining. And also, everyone, thank you so much as well for joining us tonight, because this is the topic that definitely is interesting for you. But it's also one of the topics that Dr. Tsakos is a specialist of. So we are definitely proud to be able to have you here on board and presenting those topics, because let me just tell you straight away that tomorrow we actually are going to meet with Dr. Tsakos once again, as he has another webinar tomorrow at 8 p.m. UK time. So if you didn't know that, I'm sure you will be able to join us tomorrow as well. And as you can see, the topic is the value of hysteroscopy in fertility care. And of course, Dr. Tsakos will start with his presentation. And afterwards, there will be an option for you to ask your questions. So as always, just go ahead, type those in, and I'm sure Dr. Tsakos will be able to help you out. And of course, this is going to be recorded. And so I guess that will be it from me. And I believe we can start. All right, Dr. Tsakos?
Absolutely, Caroline. Thank you so much. Thanks for the introduction. And thank you, everyone, for logging in and listening. It's been an absolute pleasure being a member of the European Fertility Society. And I have to congratulate the organizers and the whole of the scientific committee and Jakub and his team, and of course you, Caroline. It's an amazing initiative, and it all started about a year ago, so it feels as if it's been going on for years. So it's been a huge privilege for me to share some of my knowledge and also some of my uncertainties with you tonight. It's very difficult for me to put in a presentation together when this is mainly directed for patients. It's certainly different to presenting in conferences or in closed groups of specialists, as I do quite often, because I wanted to make my messages as clear as possible. And this is sometimes quite hard to achieve, especially when there's no consensus between us doctors, and especially when what is called scientific evidence is not very clear, giving the direction one way or another. So you have to excuse me, I will be a little bit scientific, but I will also try to be practical. And I would like to share also my personal opinion and experience. And when I mean personal, I mean my team's experience through the 30 plus years I've been in this field. So what is the value of hysteroscopy in fertility care? This is the main topic of today's talk. A few things to start with. Just trying to navigate. Right. For those who haven't met me before, I'm a UK trained gynecologist and fertility specialist. I have been around for more than 30 years now, which is a pretty long time. I practiced and trained in the UK for about 10 years, and for the last 20 years plus, I'm practicing from Greece, but also in the UK and Cyprus. And I've had the privilege to work with many patients from all over the world. And I have been able to also been in touch with a lot of my colleagues and friends from all over the world who have helped me shape today's form of knowledge and approach for our patients. And I have the privilege of being board member in many associations and also member of many scientific committees and scientific organizations all over the world. Basically, all of this has only one aim: to create a beautiful child a beautiful baby coming out of this shell, either naturally or through assisted reproduction. Now, one of my passions has been fertility surgery. And the reason why is the fact that in the early 90s, when I started my training in the UK, fertility surgery was part of everyday practice. In those times, IVF was not that developed, and fertility surgery was still very much into everyday practice in order to achieve a natural pregnancy. But even with assisted pregnancy, we used to do GIFT, which was a technique that required some endoscopic skills through laparoscopy. Of course, that was abandoned in the early 90s, and of course, it was vastly replaced by IVF and later on by ICSI. So now, in my opinion, over the last few years, the fertility surgical approach has been revisited. And I'm one of those who believe that it's a neglected part of the fertility care. And that has simply become a fact because of the major IVF revolution that happened over the last 20 plus years. So in the early 90s or mid 90s, for example, the IVF success was no higher than maybe 15 or 20%. And we all know now that we can quote figures double that and sometimes even more. And of course, all the scientific evidence that's emerging is generally focusing on IVF and not so much on fertility surgery. And this is not always true. The fact that the value of fertility surgery has not been highlighted doesn't mean that there's no value. And of course, there's a huge commercial drive that favors IVF. I think my generation of the doctors trained in the 90s or even in the early 2000s, the generation next to mine, are probably the last generation of specialists of fertility medicine and surgery. And now, more often than not, the fertility training doesn't include anything more than just basic fertility endoscopy in the likes of perhaps a diagnostic or an easy, straightforward hysteroscopy or laparoscopy. And certainly fertility surgery now has moved more into the hands of fertility surgeons or endoscopic surgeons and moved away from the hands of the IVF specialists. So I'm determined to keep that skill, and I'm very happy that I have been fortunate enough, my team and I, to maintain the skills of complex hysteroscopic and laparoscopic and now robotic surgery in order to assist our patients. And in my opinion, that should be part of the skills present and available within an IVF unit. Just a few minutes before my talk, I had a wonderful message from one of my UK patients who simply came to Greece and had very simple hysteroscopic surgery for uterine diaphragm and ovarian drilling for polycystic ovaries, and she went back home to the UK and conceived naturally and delivered a child. So in my opinion, fertility surgery should be revisited. Of course, there should be more evidence, more scientific evidence, and that should take into account the new data, the new evolution of endoscopy, both hysteroscopic and laparoscopic and robotic surgery. It has been neglected for many reasons. Surely IVF is very successful now, but that doesn't mean that we shouldn't strive, we shouldn't work towards improving the odds of achieving a natural pregnancy or improving the chances of artificial assisted pregnancy through some add-ons of hysteroscopy and laparoscopy. And of course, this neglected situation on fertility surgery has also been driven by us doctors. It's easier to resort to IVF for a number of indications without exploring further to find out what's going on and without providing perhaps a patient with options. And sometimes the patients are more easily moving towards IVF rather than endoscopic surgery. So they play a small part into neglecting somehow the value of endoscopy. So I will talk a little bit about fertility assessment. What is a basic test and what's an advanced test depends based on where you practice and where the patients are and what kind of doctors they see. For example, in the UK, basic is very basic. In Europe, sometimes we do more tests. In the US, they do even more tests. In Australia or in Canada, they have, in my opinion, a very good balance between the European and the US perspective. And of course, there's a lot of controversy as to what tests are considered important and what aren't in a fertility assessment protocol. Certainly, the assessment of female anatomy is part of the basic assessment, and of course, we're all familiar with the ultrasound scans. Ultrasound scanning technology has evolved, our skills have evolved, the images have evolved. We're all familiar now with the 3D and 4D images and so forth. However, in my opinion, still the assessment of the female anatomy, whether this is the cavity anatomy within the uterus or whether it's the through laparoscopy anatomy of the tubes, the ovaries, in the relationship and the peritoneum has been hugely neglected. So, in my opinion, fertility endoscopy should be applied or should be considered to be applied for what is called unexplained infertility. I think most of my colleagues would agree that we very easily label unexplained if the sperm is normal and the scan is normal, very often without even attempting to assess properly the tubes or to assess properly for conditions like endometriosis or tubal or endometrial adhesions. And in my opinion, there's not a single possible factor or diagnosis or etiology of fertility that fertility endoscopy could not or should not be applied. So what is fertility endoscopy? This is hysteroscopy that I will talk mainly today, and laparoscopy, which I will touch upon tomorrow. So hysteroscopy is the evaluation of the uterine cavity, of the internal lining of the uterus. So through a very fine tube, and of course the technology has evolved massively over the last 30 years. Everything from the camera to the optics, to the irrigation fluids, to the size of the instruments, and of course our skills have got much better. We are able to assess the uterine cavity as an outpatient in an inexpensive, easy and swift way. And in many occasions, if there is any indication to perform surgery in one time, we can always do that. So that is what a hysteroscopy involves. It's the view of the uterine lining. And why is the uterine lining that important? Because this is the implantation area. This is the implantation spot, which in my opinion has to be as perfect as possible in order to improve the chances of a successful pregnancy. However, I can tell you now that there is a small controversy around that issue. So that is what a hysteroscopy is and how it's done. And of course, the indications, as I said, are quite variable. In my opinion, one should consider perhaps a hysteroscopy if we're not very happy with the scan. With the normal scan, even with the normal scan, the chance of having an abnormal finding with hysteroscopy in a fertility in the fertility population, female population, could be as high as 30 or 40%. Now, whether this pathology, which is considered a minor pathology, is related to IVF success, failure, miscarriage, or the chance of live birth is still a little bit of a matter of controversy. However, I will give you my clear stand later on in this lecture, in this talk. So what is that we're looking for? What is that we're possibly concerned about when we are considering a hysteroscopy for patients? Now, let me explain to you a little bit the term. Hystero in Greek is the uterus, and hence terms like hysteroscopy, hysterectomy, hysteria, and so forth. And scopy is the visualization. So it's all very Greek. Terminology is the visualization of the uterus, of the lining of the uterus. So this is the sort of pathology that we may be faced with. And this is a pathology that may or may not be diagnosed beforehand with the scan. Now, despite the massive evolution of scanning technology, and despite the massive improvement of the clinicians or the technician's skill, whoever is performing the scan for you, still as a method has its pitfall, the scan, which means that it can either overdiagnose or diagnose or underdiagnose pathologies like this. But more or less, this is what we're looking for. Now, the value of hysteroscopy, there's a division of science now in the last 20 years. Up until perhaps 2010, 2015, there was some evidence, some good evidence that hysteroscopy improved the success rate of IVF and increased the chance of either a natural conception or an assisted conception. Now, between 2010 and 2020, there has been some controversy, mainly through some studies which I will very briefly present. I am very well aware that although there might be some doctors that I would, some colleagues of mine that I would be delighted to have a conversation with at the end of this lecture and of this talk, I'm very well aware that my patients or the patients who are the vast majority of our audience tonight would like some clear indication, and I would not sit on the fence, and I will give you my opinion at the end. So polyps, this is a very common finding, especially with slightly older women or women of what we call advanced reproductive age, women over the age of 35, and even more so women over the age of 40 are more likely to have endometrial polyps. What is the chance of a woman with a normal scan having a polyp? This could be as high as 1 in 3. So the accuracy or the predictive value of the vaginal scan can never be higher than perhaps 65, 70, or 75%. So there's always a chance that there's a polyp hiding and is not visible by scan. And the hysteroscopy is the gold standard in diagnosing polyps. And of course, polyps have been found to be associated with infertility, either with difficulty in conception or with IVF failure, or with miscarriages, or with pregnancy complications like bleeding and sometimes preterm delivery and so forth. So there is some evidence, not hugely good evidence, but again, there's a little bit of a bias because in my opinion, most of the studies in the last 20 years have been focusing on IVF and not on fertility surgery for the reasons I've mentioned before, and therefore there is some evidence that removal of a polyp, especially of a good-sized polyp, could improve the pregnancy outcome. In my unit, we have some studies. Actually, we presented at the British Fertility Society conference a couple of years ago in Edinburgh in a group of egg donation patients of advanced reproductive age, women over 40, that hysteroscopy and removal of polyps, even small polyps, improved the live birth rate and the delivery rates by 10%, which is a significant amount. And let's not forget also the chance of malignancy, which although very small, almost negligible for the under 40-year-old age group, it is not negligible for women over 40, and that could not be associated also with the size of the polyp. I mean, in my practice, we perform quite a few hundred of hysteroscopies every year for various indications, not just for fertility. And unfortunately, we do diagnose malignancy in a good percentage, maybe 1 or 2% of women over 40. I mean, you can imagine recently we diagnosed malignant sarcoma on a 42-year-old patient who had who came forward to have egg donation after a couple of failed IVFs in another unit. And that was much to our surprise because she only had a small, what we thought was a small intramural myoma of 3 centimeters, a little bit touching upon the uterine cavity. and that was the indication, of course, for our hysteroscopy. And much to our surprise, she had a malignant sarcoma, and of course that was treated with hysterectomy afterwards. You can imagine the devastating consequences if that diagnosis was not made, and especially if that woman was pregnant, and of course the tumor would have been advanced by the time she delivered. So in my opinion, fine, studies are important, evidence is important. Perhaps a small polyp, the chance of malignancy is not big, it's very small, but in a large practice with a large population, especially with advanced maternal age, especially with patients with multiple IVF failures, I strongly believe that there's a very good value of performing a hysteroscopy on those patients. Now, there's been 2 studies which I will mention very quickly. This is the Trophy study and the Insight study, which basically failed to show any advantage of hysteroscopy for patients before the first IVF and if there's a normal ultrasound scan finding. Of course, there was no difference. However, there's a lot of criticism that those studies have received, and I'm not going to go into detail. One of my criticism would be that nowadays there's a huge amount of patients who have had more than one IVF, so this is a very small subgroup of our patients. And how do we define normal ultrasound scan? We do not have a consensus on that, and of course depends on the technology we use, depends on the skills we devote to that, depends on who is doing the scan. As we all know, in the UK, there are some wonderful technicians performing the scans. However, there's also fellows performing the scans. There's also junior doctors performing the scans and so forth. So I'm not sure how normal a normal ultrasound scan would be. And I'm sure that if there's any colleagues on the audience tonight, they would have some stories to share, like my stories of major uterine anomaly being missed by ultrasound scanning, even by fairly experienced technicians. So there's a little bit of a gap at the moment, in my opinion, in the world evidence in terms of hysteroscopy and science behind it. There's a lot of recent wish to have validation of the science. Of course, hysteroscopy has evolved over the last 10, 20 years. There's better technology. Now we basically effectively moved on to outpatient diagnostic flexible hysteroscopy. We have better optics. We can perform an outpatient hysteroscopy within a couple of minutes without the need of any anesthesia, without the need of any particular trauma to patients. However, we still have no consensus on diagnosis, on what's normal and what's not, on the terminology and what should be treated, how it should be treated, and at what stage it should be treated. And in my opinion, this is not helping our patients. I think our patients need some very clear guidelines. And one of the limitations of the studies, in my opinion, is that there are multi-center studies and there's a lot of variability in the skills, in the terminology, the diagnosis, in the technique they use, and so forth. And perhaps the science that we have at the moment is slightly, if not more than slightly, misused in favor of IVF. Now there are various studies which show a positive value of hysteroscopy in cases of previous IVF failures. So perhaps there is an indication. I mean, in my practice, if for any reason we don't do hysteroscopy before IVF, or if patients have been referred to a unit, having failed in other units, we generally suggest hysteroscopy after a failed IVF cycle, even if the scan findings are normal. And of course, there is some evidence, although it's a little bit old, the evidence, but it's there, that even in the absence of uterine pathology, which means that even if we don't identify anything seriously wrong, by doing a hysteroscopy in patients with a previous IVF failure, the results are improved and the outcome is improved. Now, I will talk a little bit about fibroids, benign tumors, very commoner in the advanced maternal age group, especially women over the age of 40. What is the implication of fibroid? Again, infertility, in implantation, in miscarriages. Again, there's a little bit of controversy there, whether, for example, I mean, we know that the subserosal, so an external small fibroid, doesn't affect fertility, and we know that probably a submucous fibroid or an intramural fibroid that's touching and distorting the cavity is probably affecting fertility. And there is some fairly good evidence that this is the case. I do have the evidence somewhere down here. But what I wanted to mention to you is that certainly these are the images that we would have. This is a 3D scan that shows a fibroid that's distorting the cavity. This is through a sonohysterography, where we can clearly see the cavity being distorted by a fibroid polyp. This is what it looks like on hysteroscopy, and this is another hysteroscopy view with adhesions. So, as a clinician, but even as a patient, I would prefer not to have that image before I went on to doing IVF. I would prefer something like this. Now, of course, you know, anyone could get pregnant even with the presence of this polyp. You can all understand that if the implantation happens somewhere here, this is normal endometrium, and we've all seen patients getting pregnant with polyps, with fibroid, with bigger polyps and bigger fibroids. But in my opinion, I would prefer to have an optimum area of implantation, especially for patients who have had at least one failure in the past. Now, this is a paper I was looking for in order to find recommendations about fibroids and fertility, and this is a Cochrane, which is a very scientifically sound citing and publication, where indeed submucosal fibroids and intramural fibroids of a large size indeed significantly impair fertility. So we should be considering removing those, although subserosal external fibroids may be of no significance. Now, in my opinion, this is the ideal setup, and this is the setup that we proudly possess in my practice, and we've had this for almost 20 years. Of course, the technology now has got better. We have 4D ultrasound scans, we have flexible hysteroscopes, we have all sorts of operative hysteroscopes, and all this can be done as an outpatient procedure. So when we evaluate our patients from all over the world, I mean, you can imagine having a patient coming for a pre-IVF visit for 1 or 2 days. We want to make sure that we're very happy with the cavity before we design the operation protocol and the fertility protocol. And of course, the majority of the patients who visit us, either local or international, they've had not just one, but multiple IVF failures or miscarriages in the past. So in my opinion, this is the digital hysteroscopic clinic, which should be available in every IVF clinic, in every fertility center, in order to provide our patients with very quick, very easy, one-step diagnosis and treatment. So a few words before I finish. My personal stand, my personal opinion. I think that fertility medicine and fertility surgery should work together. I think we should reintroduce fertility surgery or fertility endoscopy, if you prefer, into the fertility care approach. We should not just focus on IVF. Fertility care is not just IVF. Fertility care is optimizing, in my opinion, optimizing the conditions in anatomy, in hormonals, in lifestyle, in body and soul, in men and women, in order to improve the chances of natural conception and, of course, improve the chances of assisted conception. And in my opinion, without fertility endoscopy, this cannot be achieved. Reproductive specialists, in my opinion, may have or must have expertise in all methods, and if they can't, they should have fertility surgeons, experienced fertility surgeons, part of their team here sitting next to us and discussing all the options with the team and of course with our patients. It's very important to counsel our patients about the options. Hysteroscopy is definitely safe, it's definitely easy, and it's definitely affordable. It is a valuable tool, in my opinion, in fertility diagnosis and fertility care. The value of a single center is very important, and I think that we should all work together in a way, and we should all design some studies to provide some new evidence, and maybe that in the hands of single surgeons in a single setup, in a single center, and definitely we would welcome further studies. A few words about Greece. Greece is welcoming patients from all over the world. Even through the COVID pandemic, we've been very lucky. We've had very low impact of the pandemic. Now everything is virtually fully opened, and even Greece is opening for tourists from the 15th of May onwards. It's been a success story, and I'm very happy to share it with you. This is my beautiful little town of Thessaloniki in the north of Greece. This is the White Tower, which is the city symbol. And this is where our clinic is based, very near the center. And this is part of my team who helped me prepare this talk for you. Thank you for listening, and I'm very happy to answer to the questions. Thank you very much.
Thank you so much. As always, a brilliant presentation with lots of interesting information, and thank you as always with all the details. And we do have some questions ready, as you can see. And I just want to mention that we now have our Q&A session. It will last approximately 30 minutes. So don't hesitate, okay? Just go ahead and type those in, and Dr. Tsakos will definitely help you out, okay? And I believe we can go ahead, as there are some of the questions coming up. So the first one, okay, is hysteroscopy done under anesthetic?
Generally, no, it's not. I mean, basically, there's three types of hysteroscopy. One is the office hysteroscopy, in which we use the flexible hysteroscope. I'm sorry, I was meant to bring the equipment here, but it's all sterilized and ready for tomorrow, so I can't do a live demonstration. So usually we start with the flexible hysteroscope, which is a very fine instrument. It has the size of a cable. I mean, it really looks very much like this cable, only that at the end it has a fiber optic ending, and of course we use very high quality cameras and lighting sources, so we just look inside, and at the same time our patients look inside. It's a little bit more uncomfortable than a vaginal scan. So there's no anesthetic needed for that. There's no priming of the cervix needed for that. Sometimes if the patient is a little bit agitated, we may give them a little bit of Panadol, half an hour before, but that's it. Now, if there is pathology there, we can always remove it, again, without an anesthetic. But if there's a big pathology, then we do it in the setting of the operating room, and we can provide an anesthetic straight away and remove the pathology.
How it works. Okay. Next question that we got from Karen: when doing hysteroscopy, that found, is it treated during the procedure or at a later point?
Well, put it this way. Invariably, we do a high-quality ultrasound scan before we do a hysteroscopy. So if we see any pathology on the scan, then we decide whether that would be pathology treatable under no anesthetic or under local anesthetic, or whether it would require a sedation or general anesthetic. So normally we plan this beforehand. Now, if on scan we identify no pathology, if it looks normal, if everything looks normal, or if we identify small pathology, either a small polyp or a small adhesion, or if we're not sure if the fibroid is distorting the cavity or not, then we start with a diagnostic hysteroscopy, and usually we finish with with a no anesthetic hysteroscopy. Of course, this has to do with the patient compliance and the patient collaboration as well. Most of our patients, and I have to say that this is the vast majority, more than 90%, they tolerate diagnostic hysteroscopy with no problems at all. But of course, if someone becomes a little bit agitated, or if for some reason they feel uncomfortable, we stop the procedure, we give them sedation, and then we move on. We try to complete everything as a one-step approach within the same session, which usually doesn't last longer than 20 or 30 minutes.
All right. Thank you for the question, and there's a thank you from Karen for you as well. Okay, next one is, what causes the improvement in IVF after a negative hysteroscopy?
Okay, Karen, I mean, you're drilling me here. There's a lot of proposed mechanisms. One is the general slight inflammation, not infection effect of the hysteroscopy itself, either through the water irrigation or through the little bit of scratching we may do by taking a small sample of the endometrium. So this is the most popular proposed mechanism. In my opinion, it's not just that. It has to do with the fact that we ensure that the cervix is not stenosed. So by doing a hysteroscopy beforehand, we've done a very good mock trial transfer. We have ensured that the cervix is not closed, and therefore that would guarantee better embryo transfer when we do IVF. This is very important in my opinion. It may well account for a good 10% increase of our success rate, because we have ensured that the endocervix, the cervix of the uterus is normal, and if it's not, we may do a small dilatation on the spot, which would facilitate the transfer. So there's a lot of mechanisms that may be implicated, but the most popular one is the effect of scratching and of causing this mild inflammation into the endometrium.
Wonderful. Thank you so much. And a big one as well. Is the same improvement with pregnancy after hysteroscopy?
The way I look at hysteroscopy, I don't look at it as surgery. I don't look at it not even as endoscopy. I mean, I look at it as the gold standard in ensuring that the endometrium, the lining, the implantation spot is normal. In my opinion, this is a very valuable piece of information in a fertility workup. So if we see an improvement in natural pregnancy or not, the answer is depends. So for example, depends on what patient we're doing it for. So if we're doing it for an unexplained infertility young couple with normal sperm in normal tubes, yes, indeed, that would improve their natural fertility chances. If we're doing it for a mid-40s lady who's planning to undergo egg donation, perhaps the natural fertility chances are not going to significantly be improved, at least not in a way that's countable. So it's very difficult to answer that, but in my opinion, it has a place in most of our fertility patients, improving what could be improved, if you see what I mean. It's not going to have any effect on the egg quality. If somebody is of advanced maternal age, it's not going to have a serious effect on endometriosis, if somebody has endometriosis affecting their fertility, but it would definitely give us the confidence that at least the factor that is important is carefully evaluated, and at least we have eliminated any serious adverse involvement of pathology that has been undiagnosed. I mean, I have performed hysteroscopies on many women with uterine diaphragms that have been missed by ultrasound scan, even performed by very experienced people, even performed by very high-tech equipment. of course, we all know this could be very well associated with not only with IVF failure, but with adverse pregnancy outcome.
And again, thank you for that. Have a look at the question. Next page. How much does the oncologist cost your clinic? I have surgical anesthetic. I have not had something like that.
Caroline, your sound is breaking up a bit. I don't know if there's a problem your end or my end.
Let me know if you can hear me now. I hope.
That's better. That's better. Okay. Well, I'm sorry, I'm not allowed to speak costs on this webinar. However, I would be delighted to ask one of my colleagues to answer that if you send us an email to info@embryoclinic.eu. The cost is minimal. With London standards, it costs as much as a highly specialized ultrasound scan, just to give you a slight indication. And of course, the reason why is the fact that we consider it part of our basic workup, and of course, we consider it as an important factor in giving us insight into the couple that we're dealing with.
All right.
So it's a very small cost. It doesn't require anesthetic. It doesn't require any pre-op assessment. It doesn't require the COVID PCR testing that at the moment in Greece is required for any patients that undergo sedation. So if you require sedation for any procedure, whether it's IVF, egg collection, or even embryo transfer, or an operative hysteroscopy, a COVID test is required. So no COVID test is required for an office hysteroscopy. So the cost is significantly reduced.
Again, thank you so much, of course, for that. And next question, how big should be a set for a resection be?
Well, difficult question, and I can't really answer, to be honest. Depends is the answer. It's not just the size, it's the location, is the whether it's associated with other factors, whether it's associated with previous implantation failures, or whether it's associated with miscarriages or preterm labors and so forth. So we try, Thessaloniki is one of the, the capital of congenital anomaly classification. As you probably know, our Professor Grigoris Gabizis, is the chair of the committee that evaluated and redefined all the congenital uterine anomalies, and he's made a huge impact with his team and of course the FRCOG collaborators. So in Thessaloniki, we do value the importance of classifying and of course designing what's best for its patient. So the clear answer is depends, because of even metroplasty or septum resection doesn't come with no potential consequences. But in my personal opinion, and in our team, we have a series of hundreds of patients who've undergone metroplasty. To be honest, if it's someone with failed IVFs and if it's someone with implantation failures or miscarriages, to be honest, I don't feel very comfortable if I don't resect the septum, even if it's a small one, touching just 1/3 of the uterine cavity.
And again, thank you for that explanation. Next question is, so you said that fibers outside the uterus below may affect fertility. How close are you about?
Yeah, you're still breaking up, Caroline.
Okay, I will double check it, okay?
This is better now. This is better.
Okay, so I guess we just need to wait. Okay, I just need to wait a little bit before I start, so sorry about this.
Mm-hmm. Now, I can see this question, if I can read it out for you. Outside the uterus fibroid may affect fertility. How close are you talking about? Basically, I don't like the lining, the endometrium, to be malformed, to be pushed, to be pushed to the side, or I don't like the fibroid to be just underneath the mucosa. So how close is close? If it's just underneath the mucosa and if it's small, perhaps I would consider leaving it. If it's an intramural fibroid that is not distorting the cavity very much, I may allow it to be there, provided that it's not bigger than 3 centimeters. And again, depends on whether that patient has had previous IVFs before, or previous unexplained implantation failures before, or previous miscarriages before. It's very difficult. I mean, in my practice, I think the most difficult cases are the gray area cases. I mean, if somebody has a huge submucous fibroid or a fibroid polyp, yes, it's pretty straightforward. That has to be removed. If someone has, I recently had a relative of mine who came from overseas with a 9 centimeter intramural fibroid. I refused to do IVF on her. And then she went back to her home country, and then they refused to do surgery on her. And then eventually she had IVF, and it was successful. And she had a fairly good pregnancy. Yeah, she had a bit of pain. The fibroid became 15 centimeters in pregnancy. But then she had a delivery. She had a cesarean section. Everything went fine. She bled a little bit and so forth. So there's always extreme examples of women with huge pathology doing very well without surgery. But in my opinion, it's not just the outcome eventually. It's the patient experience which is important. I mean, I find it very hard to justify leaving a fibroid of 5 or 6 centimeters, which is perhaps in the muscular layer of the uterus, which in case of a successful pregnancy would definitely double in size, would most definitely cause pain, would most clearly and definitely lead to a cesarean section and possibly a little bit of bleeding or a lot of bleeding. I find it very difficult to justify it. I mean, mainly perhaps it has to do with my training. I mean, in the UK in the 90s, we were not just fertility specialists, we were also surgeons, and we were also obstetricians. We were delivering our fertility patients, and I've been fortunate enough now in Greece to work with a wonderful team of gynecologists, and we still deliver fertility patients. So it's very uncomfortable, even after a successful IVF attempt. It's very uncomfortable to have a 15 centimeter fibroid at 37 weeks of pregnancy and a woman in excruciating pain. It's very uncomfortable to answer the question of, doctor, why didn't we remove it beforehand? So I try to individualize, I try to discuss with my patients. Of course, it's not always easy to remove a fibroid, especially if it's a small one. If it's a 3 to 4 centimeter fibroid, which is deep into the muscular layer of the uterus and may not be visible with laparoscopy. It's not very easy to find it. You can't palpate the uterus to feel it. Of course, you don't want to do an incision. You don't want to do laparotomy. I've had patients who've been operated on twice through laparoscopy, and the intramural fibroid of 3 centimeters was not identified, was not removed. And then we had to do robotic surgery, which sounds a little bit of a joke, using all this technology in order to remove a 3 centimeter fibroid. But yes, it may need to be done. And yes, it may affect fertility, especially if it's very close to the endometrium, and especially on patients with multiple IVF failures. So we may even need to use the robot, the Da Vinci technology, with the amazing endoscopic ultrasound system that would locate the deep fibroid into the muscular layer, but then we would know where to do an incision, remove the fibroid, which may sound ridiculously small at the time, but yes, it may affect fertility implantation and eventually the outcome of the pregnancy.
And excellent. Thank you so much. I hope you can hear me well right now.
Yes, I do.
Okay, perfect. Let's have a look at another question. In which Mullerian anomalies do you recommend operative hysteroscopy?
Well, to be honest, I mean, I know there's studies going on at the moment. I'm really looking forward to the outcome. There is some preliminary data that perhaps small diaphragms or medium diaphragms may not be that important. I doubt it. I mean, I think they are important. And I think not only can they cause implantation failure, but also they cause miscarriage and they cause potentially preterm labors. I mean, of course, in my gynecology practice, I have seen, recently I did a hysteroscopy on a postmenopausal woman in my gynae practice who had an absolute complete, almost, uterus didelphys. She had basically a huge diaphragm of the uterus, and that was totally undiagnosed. And she had delivered through cesarean section children without knowing. And, she became 70 years old to find out that she had a diaphragm. But in my opinion, I think this is the exception. For the majority of uterine diaphragms, I think there is a value and there is a point in performing some sort of mitroplasty to improve the chances of a successful pregnancy.
Excellent. Thank you. Yet another story. All right, let's have a look at this one. So what is the optimal waiting time after hysteroscopy with fibroid removal before proceeding with egg donation?
Well, the answer is depends on the fibroid, depends on how big it was, depends on how big a base it had. For example, you can have a fairly large fibroid with a small stem, which means that the damage to the endometrium is minimal, or you can have a smaller fibroid with a large base, and so forth. So I think, in my opinion, a couple of months, no longer than that. I think, in my opinion, within 6 weeks or within a couple of menstrual cycles, the lining returns back to normal, depending again on the extent of the insult of the uterine lining. I would like or not like to do a second look hysteroscopy to ensure that all the healing has been perfect and that there's been no adhesions before I move on to the egg donation. I must admit that for the majority of my egg donation cycles, the vast majority of my egg donation cycles, especially with those over 40 years of age, and especially for those with previous IVF failures, I strongly suggest a diagnostic hysteroscopy. And I must say that the majority of the patients are very happy to accept it, and the majority actually request it before even suggested. And it facilitates, it gives us huge confidence. It rules out quite a lot of pathology that otherwise we would be unaware of. And also for the over 40s, I always do an endometrial biopsy to ensure, not only to exclude endometritis and such factors, but also to ensure that there's normality. Sometimes we pick up atypia, we pick up endometrial hyperplasia and atypia, which needs careful attention, which may need some progesterone treatments before we embark onto the egg donation. So for my egg donation cycles, invariably I do suggest a hysteroscopy.
Excellent. Thank you so much for yet another thorough answer. And we will be slowly finishing, okay? There are some questions left, but of course, remember that if you have more questions, Dr. Tsakos will be happy to answer them for you. I will simply forward the questions that we have left. And of course, I'm sure he and his team will be able to help you out. But we can answer one of the questions again still, I guess. So can you have hysteroscopy during stimulation phase of IVF?
The answer is possibly yes. Depends. If it's, in my opinion, you can do a diagnostic hysteroscopy, no bother. And, if it's done, say, in the early follicular phase, you may even proceed with first embryo transfer if you haven't really done anything operative. Ideally, not. I mean, if I have any doubts about the uterine pathology, and if I'm not very happy with the first embryo transfer for any reason, I sometimes suggest and perform a hysteroscopy during the sedation of the embryo of the egg collection. So, in my opinion, if we are to perform a hysteroscopy during an IVF cycle, in my opinion, the best time is to do it during egg collection. Now, whether we do a first embryo transfer on that cycle or not, to be honest, I don't do a first embryo transfer when I've done an egg collection hysteroscopy, because invariably when I do this, I have strong suspicion that there may be a pathology, and usually this is proving to be the case.
Wonderful again. Thank you so much. Dr. Tsakos, one final question for tonight. Yes?
Mm-hmm.
All right, perfect. So let's have a look, okay? But we had problem doing the hysteroscopy with DNC. It was performed properly, but not this hysteroscopy in ERA. On both instances, our doctors is not able to get into the uterus to see if any problem is there. How we should go about this situation? We had 2 failed frozen embryo transfers.
Right. Okay. I mean, difficult to comment on that. But if they fail to do hysteroscopy, that probably means that you have some sort of cervical stenosis or adhesions or both. And it's a little bit curious as to how a DNC was performed and then a hysteroscopy could not perform, because DNC means that blindly an instrument goes into the uterus and takes a sample. So I cannot really explain how that blind instrument went into the uterus and then an instrument with the light and an eye at the end of it cannot go in. So in your opinion, in your case, in my opinion, I would probably suggest that you consider having a hysteroscopy at some stage to clarify whether there's a stenosis, whether there's adhesions, whether there's both, and of course try to optimize the conditions as much as you can, and optimizing both of them might have a positive effect on embryo transfer and implantation, because if you've had a failed hysteroscopy, you are at a very high chance of a very difficult embryo transfer or of a failed embryo transfer. So I would possibly suggest considering a diagnostic hysteroscopy before you move on.
Wonderful. Thank you so much. Once again, it's been great to have you here for sure. So thank you for answering all those questions. As you can see, more patients of ours are typing in, but of course we will be finishing for tonight, okay? It's quite late in Greece, so we definitely want to have Dr. Tsakos well rested for tomorrow, right? Because lots of things to do. But don't worry, okay? As I've mentioned, I will forward all of your questions to Dr. Tsakos and his team at EmbryoClinic, and I am sure they will be happy to help you. Dr. Tsakos, thank you so much. As you can see, there are plenty of thank yous and comments right here for you. As always, it's been brilliant to have you. Before I let you go, anything else you would like to add?
I would like to thank you, everyone. Thank you, Caroline. Thank you, the European Fertility Society, for the invitation. And of course, thanks to my wonderful audience, stimulating, wonderful questions, difficult questions. You gave me a good grilling today. Thank you for this. As a conclusion, I feel that a hysteroscopy is a very valuable tool in diagnostic care in gynecology, not just in fertility, but generally in gynecology. The technology has improved massively. In my opinion, office hysteroscopy should be part of our everyday practice. It would take away a lot of uncertainties, and it would give confidence to both our patients and the doctors. And of course, in fertility, this is very important. I mean, there's a lot of add-ons in fertility care. There's a lot of questionable and tests with very poor evidence background. In my opinion, a hysteroscopy an office diagnostic hysteroscopy is no more than just an advanced type of scanning, an advanced type of diagnosing the pathology and ensuring that at least one important factor, one important part of the equation of a successful fertility, either spontaneous or assisted, has been ensured and has been ruled out any pathology, at least important pathology. So it's not a huge impact in terms of the approach to our patients. It doesn't hurt. It's inexpensive. It's in my opinion, it should be on the bedside of the fertility clinic, but even for standard gynecology setup. I mean, if I go back in my times in the UK, we didn't even have a scan at the time. I mean, we were doing outpatient gynae clinics in the 90s, in the early and up to the late 90s, without scanning facilities. We still used to do bimanual examination. So now in a modern clinic, now a scanner is always there available. And I think equally an office hysteroscopy should be part of our diagnostic tool. And this infertility may prove very, very valuable. Thank you very much and have a lovely evening, all of you.
Thank you so much indeed. And of course, it's been a brilliant session. I love that how you engaged you are, and of course, with your wonderful questions. Dr. Tsakos, is always a pleasure. And let me just repeat once again, tomorrow at 8 p.m. UK time, Dr. Tsakos is back with another topic, this time laparoscopy. So don't miss it. Just go ahead and sign up if you haven't already.
And robotics, not just laparoscopy.
Exactly. So this is something that's going to be also interesting. So go ahead and sign up. And of course, I hope to see you there tomorrow. And as you know, it has been recorded. So of course, you will have a chance to see it. Once again, it will be uploaded on our site, My IVF Answers, tomorrow morning as well. Thank you so much, everyone. Have a lovely evening and see you tomorrow. Okay, Dr. Tsakos?
Take care. Thank you so much. Thank you.
Thank you. Bye.
Bye.